I'm quite aware that I'm following on from King Charles's address to the Congress, which is quite a hard act to follow, but I will try my best. And my topic, as Paul says, is understanding neuropathy in the setting of Waldenström. A bit of background, I have been working on Waldenström's for 20 years or so. And within that, at our hospital, we have a national hospital for neurology. And I started doing joint clinics with a peripheral nerve specialist for the past 15 years, Professor Michael Lunn. And I've learned so much about sitting with him in a room, seeing patients with neurological conditions. And so I'm hoping to share some of that with you. And so here we go. So the overview of my talk is to go through the elements of the nervous system, the symptoms and causes and current approaches to managing neuropathy. I'm going to go through 3 cases from our clinic, and I think it might be an idea if the organizers agree that after each case, maybe we can just pause for questions, because each case is a little bit different to the other. And then I'm going to mention really some of the really important features to mention to your doctor if you have nerve problems. So here's a map, if you like, of the nervous system. And the peripheral nervous system is everything that is not the brain or the spinal cord, but it's everything else. It's the electrical system that powers us to function, to live. And it does far more than we realize until it doesn't work so well. Apart from the sensory nerves, the motor nerves, there's also a very important system called the autonomic nervous system, which you could also talk about as being the automatic nervous system, because it's kind of working away in the background to keep our vital systems functioning. There's 2 branches, the sympathetic system and the parasympathetic. And the sympathetic system is to do with the fight and flight response. So it really works on pumping more blood into the system in times of stress, raising your heart rate, raising your blood pressure. And the parasympathetic nervous system is the rest and digest system, which is enacted when we are rested and relaxed. And just FYI, it's really good to tap into your parasympathetic nervous system as much as you can, and there are different ways of doing this, because it's a good way of de-stressing. Excuse me. So you've probably read these kind of sentences when you look up neuropathy. It affects about 20% of people with WM at diagnosis, and about up to 50% of people will have neuropathy symptoms at some time in the course of their disease. You'll read things like demyelination, you'll read about MAG, anti-MAG antibodies, you'll read about axonal neuropathies, and different kind of titers of MAG. I often get asked about that, the level of the antibody. And then there are other things like amyloidosis and cryoglobulinemia, vasculitis. So this is the way doctors think about neuropathies in Waldenström. So let's try and break that down a little bit. So this is a Venn diagram of how WM and IgM interact with nervous system situations. So there is the disease itself, the lymphoma, which, as Steve Ansell said, resides in the bone marrow and may also be found in lymph nodes, spleen, and other areas, so-called extramedullary disease. The cells can also go into the nervous system and cause Bing-Neal syndrome. We just heard about that too. But the IgM also has issues which it can cause through cryoglobulinemic activity, which is when it sticks to itself in cooler temperatures. And that can cause a range of problems with circulation, which can affect the circulation to the nerves as well in those circumstances. And that can cause nerve dysfunction and inflammation over time. Then there's this other protein depositing condition, amyloidosis, which is when you get these misfolded proteins. For some reason, we don't know why that happens in some people, but it does happen. And that can cause, that can affect the heart, the liver, the kidneys, the nerves, can be in the bone marrow, etc. So that can be a multi-system problem. And it's important to identify it if it's there, because it does affect the way we treat the disease. It can also affect the autoimmune system. Then there is a whole range of, the IgM has autoimmune activity against a number of elements in nervous tissue. So that's another group of diseases, and anti-MAG comes under that. So these are the kind of questions that is helpful to prepare before you see your doctor with neuropathy symptoms. Bear in mind you will be seeing, for the most part, a hematologist, and hematologists are not neurologists, so they may not delve into your neuropathy in this kind of way, but this is certainly what we do when we see our patients. The questions that doctors think about in trying to decipher neuropathy symptoms is there a neuropathy in the first place? Just because you have pain or other symptoms, it doesn't mean you have what's called a large fiber neuropathy. Some of the small fibers can get damaged and they can cause a lot of pain, but that isn't the same as a large fiber neuropathy, which is something that can happen in Waldenström's and is more likely to need or to be treatable. The second thing that we ask ourselves is if it is a neuropathy, is it related to the Waldenström or the IgM? Quite often we see patients with anti-MAG neuropathy, an anti-MAG antibody and a neuropathy, but they're not connected. And some of these patients, by the time they come to us, they've already had a round of rituximab, and it turns out that it wasn't anything to do with their WM. So that is immunosuppression for no reason. So it's really, really important to make that connection. And this is where you need someone who can hopefully make those interpretations of your symptoms and your signs. We ask ourselves about the pattern of the neuropathy. Has it started in the feet and come up the legs? Is it symmetrical? Is it more weakness or sensation? How quickly is it changing? And if there is a neuropathy, what is the actual diagnosis? And therefore, what is the correct treatment? And what else can we do about someone who has neuropathy symptoms? So, case one is a gentleman of 64 who, by the time he came to us, he'd had symptoms for 4 years or so. He had pins and needles in his his toes, gradually spreading upwards to the top of his shins. His fingers and hands were affected, and he developed tremor. And this was worse when he was sort of stressed or hungry or something like that. He also had poor balance, so he wasn't really able to close his eyes and wash his face or wash his hair in the shower. He had to hold on to something, to do that. And when we examined him, I say we, the royal we, he was found to be unsteady with his eyes closed. There's a test called the Romberg's test where you get the patient to stand still, close their eyes, and then see what happens. And if they wobble too much, then you know that they are really struggling to maintain their balance. And that gives you clues as to where the problem might lie. His strength was normal, but his reflexes were absent. And he had reduced vibration sense, which is when they bang a tuning fork and put it on you, up to the ribs. And he had reduced joint position sense in his feet, his toes, and reduced pin prick to his mid-shins. So there was definitely sensory deficit going on here. We did some blood tests, and he had an IgM kappa paraprotein, and he had strongly positive anti-MAG antibodies. Now, thing about the level of anti-MAG. First of all, anti-MAG is present in pretty much all of us. It's just an existing autoantibody that we have. For the most part, it doesn't have any significance. But if it continues to rise in level, it may become significant, but not always. So we have 3 levels of positivity. One is just low-level positivity, one is moderate, and one is strongly positive. And as a general theme, the stronger the positivity, the more likely anti-MAG could be instrumental in causing a neuropathy, but it's not inevitable. So it's like any autoimmune condition. You may see a rheumatologist and have a strongly positive autoantibody, like rheumatoid factor or something like that, but you may not have rheumatoid arthritis, okay? So antibodies alone don't tell the story. It's the significance, the impact, that's what counts. So he had strongly positive antibodies, and his clinical picture was indicative of possible anti-MAG neuropathy. He went on to have nerve conduction tests, and this showed what's called slowed conduction. Now you can see in the top panel that when the nerve fiber, the wire, is affected by whatever process, you get a reduction in the amplitude of that wave, which is the way you measure the current that goes through the nerve. And that tells you it's an axonal neuropathy. In the lower, excuse me, I've got a frog in my throat. In the lower picture, what happens is that the wire is preserved, but the myelin, which are the sort of the insulation bits, is damaged. And that slows conduction. So sometimes you get a mixture of these two, but in his case, he had conduction slowing. So our conclusions were that he did have a neuropathy because it was clinically present and confirmed on nerve conduction tests. It was related to the WM because there was sufficient evidence for the pattern. He had positive anti-MAG, strongly positive. He had a gradually progressive conduction slowing. It was predominantly starting in the toes and moving upwards, which is called length dependent. Now, if you think about nerves, if they're getting damaged, one of the longest nerves in your body is your sciatic nerve. It's one nerve, so it gets all its, the powerhouse is right at the top. And so by the time you get to the bottom of that nerve, it's still receiving sustenance through the channels that go through that nerve. So if there's damage, the bit that gets worst affected is the furthest away from the powerhouse, the place where it gets its nutrition, etc. So it's a length-dependent problem, and he also had so-called ataxia. So he wasn't sure he couldn't feel where his, the sensation for where his body and was in space was lost to him. And joint position sense is really important for us to be able to move around comfortably. So, yep, anti-MAG neuropathy is the diagnosis, and we went on to consider treatment. And we also, because he had pins and needles, which were very uncomfortable, we treated him with gabapentin. And because he had tremor, we used a beta blocker called propranolol, which can help to slow down the tremor and make it more manageable. So just a quick thing about anti-MAG neuropathy. So the purplish picture is a section through a nerve, and that shows little nerve, is showing the small nerve fibers going through in bundles, okay, making a nerve, biggish nerve. And within that, you can see under much higher microscopy on the left, is a sort of section of the different elements of the nerve. And then in some cases, if you do a nerve biopsy, you can do a special test called electron microscopy, which is a huge magnification. And you can see that in anti-MAG neuropathy, the myelin, which is like an onion appearance, rings, have been separated by the presence of the anti-MAG antibody. And that is what is actually happening at the ultra sort of structural level, which is causing the problem with the damage to the myelin sheath. So when do we treat anti-MAG neuropathy? Well, first of all, you have to establish that it's actually anti-MAG neuropathy. Not everyone with anti-MAG neuropathy needs treatment. A bit like Steve Ansel said earlier, one has to be very measured in giving treatments to people because they have downsides, especially to the immune system. So in general, we would consider treating anti-MAG neuropathy if it's progressive and impairing function. And the options we have available to us are rituximab-based combinations. So the way we practice is to, if we need to treat someone with an anti-MAG neuropathy, is we will stage them to see what the level of their disease is. And if they have a significant burden of lymphoma in their marrow, then we would consider actually giving them DRC, in other words, cyclo with rituximab, even if their hematological condition didn't need treatment. The idea being to reduce the factory that produces the antibodies. In our experience, we feel that if someone can tolerate the DRC treatment, we'll probably get a better outcome going forwards for the nerves. So that tends to be the way we've been moving. But you can use rituximab more than once. You need to be patient for responses. It can take several months to see a response. Sometimes all you get is a stabilization or loss of getting worse. It really depends where your nerves are on this journey and how much established damage there is. Nerves can recover, but they take a long time to do so. And if there's significant damage to the wire, the axon, there may be limited recovery. BTK inhibitors can also be used. There are a couple of trials looking at zanubrutinib and anti-MAG neuropathy. We ourselves have gone on to use BTKIs in some of our neuropathy patients with varied success. I mean, every patient is individual, so it's difficult to be didactic about it. And there are newer medicines in the pipeline. I must stress again that one has to treat the pain with various medicines because that's what affects people a lot and interferes with their life. Tremor, there are many medicines to try and counteract that on a sort of escalating scale, including injection of Botox into sort of some of the muscles in the hand sometimes to stop the actual, at least one muscle, and therefore it doesn't have to keep moving back and forth. If you're at risk of falling, one has to be very careful in terms of physical therapy, balance exercises, using aids if necessary to support you, even though that may feel like a defeat. It's better that than a fall. And maybe just in a selected way. At home you may be fine, but if you're going out and about, it shows people that you may need more space, and people usually give you more space so that you can walk in a more comfortable way. And if you have foot drop, there are many kinds of appliances that help to raise your foot. So it's good to see an orthotist who can help find you the right kit to help your feet. There's literally dozens and dozens of them, so there's going to be one that's right for you. And what about the prognosis of anti-MAG? So many patients are pretty stable, even without intervention. It's very slowly progressive in the majority of people. But for those who need treatment, as I mentioned before, if there's a lot of established nerve damage, you're going to get less remarkable recovery. So there's a sweet spot. If you can capture someone who has a neuropathy that's getting worse and accelerating and you get them at that point, then hopefully you will arrest that damage and they can improve better and to a greater extent. Using the correct treatment is obviously important. There's no way of knowing in advance which is the right treatment for which person. So keeping an eye on that individual over time will help you to say, look, I think we've done the right thing here, or we need to change. We need to maybe consider a different treatment or moving on to something else. The other thing to remember is that even if we can't make the nerves heal up, our bodies have an amazing capacity to adapt. So with perhaps some aids, like something to stop your foot drop, control of pain, some physical therapy, our bodies are more than the sum of the parts, right? A little bit of improvement here and there can actually improve mobility to a good extent. So I think one can I'm often really impressed with the kind of improvements people experience after treating the neuropathy, even if it's not been made fully better. So at that juncture, I wonder if we have any questions around MAG-type neuropathies. There's a mic on its way.
In the use of rituximab and a patient who might respond positively, what are your thoughts? And I know it's very controversial in other adaptations for Waldenström, specifically in the treatment of peripheral neuropathy, to create a program after the initial Rituxan by 8 to do maintenance Rituxan to maybe keep the IgM down or drive it a little lower?
Yeah, I mean, that is a great question. And I think, I mean, it's one we've asked, the community has asked itself. It's how low do you need to go with the IgM? And that is quite problematic because it's not that easy to get complete responses with the therapies we have today. Perhaps an exception might be bendamustine and rituximab, which can give a deep response. But in the setting where neuropathy is the main reason to treat, that seems very heavy-handed. And I think there's more risk from that in terms of immunosuppression. In terms of like rituximab maintenance, we tend not to advocate that because there's no good evidence that it does lower the levels that are relevant to neuropathy in the way that we want them to. So you may see your protein levels go down over time, but again, it's not felt to be justifiable to do that sort of treatment, in my opinion, actually. And the other thing is that sometimes you don't need a lot of the MAG. It's sometimes in there, and it doesn't come. You can't flush it out. So it's quite a complex dynamic. But I see where you're coming from. It makes kind of sense, but we haven't found the right recipe, if you like, to deplete the IgM in a proportionate way in this kind of setting.
I was wondering if this gentleman did have, in this case, if he did have an EMG nerve conduction study, and what was the pattern there, and is there a typical pattern that we see on EMG nerve conduction study with these neuropathies? And does it differentiate from other types?
Correct, it does. So he did have nerve conduction studies, and his showed this conduction slowing. And he had a very specific feature, which neurologists, electrophysiology doctors are well aware of, called prolonged distal motor latencies. Now, that was explained to me some time ago by a neurologist, but I've forgotten exactly what it means. But so there are characteristic features in nerve conduction studies that make a diagnosis of anti-MAG more likely. But there's no one sign that is, yes, it's diagnostic of anti-MAG. There is a bit of overlap with some of the other demyelinating neuropathies. But absolutely. But I believe that actually nerve conduction tests are more of a confirmatory thing in the whole picture. The history is really important and the examination is really important. And that is really why I'm a great believer in working with neurologists very closely, because as hematologists, we don't have that. We don't have time to develop that skill to that extent. So that the history is really important, the exam, and then the nerve conduction test usually is what it kind of confirms or gives you a surprise, and then you think again about what's going on.
Hi, thank you so much for being here. I had a question about the sweet spot for treatment. And I was wondering what kind of time frame on average is typical? Are you thinking about by a few days intervention should occur, or maybe after 3 months there's an indication maybe this is the sweet spot? I was just kind of curious about that, please.
So it's definitely not days. It's usually months. So if we see a patient and we're thinking, is it time to treat? We have the option of seeing them in like 3 months, and we sometimes do that. If we have any uncertainty about the benefits of going ahead versus not going ahead. And I think that goes for a lot of Waldenström treatment generally, is you do have time on your side it's very rare that you have to rush into treatment. So in our practice, we tend to, if we're sitting on a fence, we tend to say, look, let's see you again. And we use this score called the ROD score, which is a functional score which is done by the patient. It's a questionnaire about different things they can do. And there's a specific one for MAG, neuropathy. We will get a line in the sand and then we'll repeat it and see if there's a deterioration. So we do try and base it on whether there's a downward change in functionality. Yeah. Yep.
About 6 or 7 years ago, there was a clinical trial, I believe in Europe, for a drug that would remyelinate the peripheral nerves. The trial failed, or it was stopped, and I don't know why. Are you aware of any work that's being done to remyelinate the peripheral nerves? And I know they're working on this for MS, which is central nervous system. Would remyelinization be the same for both?
So I think I'm not specifically aware of that particular trial that you mentioned, but knowing what I do about myelin is that it's a very complex structure. So MAG stands for myelin-associated glycoprotein. There are many other proteins and fat-like substances that make up myelin. And you can see from the ultrastructure on that electron micrograph, it's structurally very complex as well. So I think remyelination is quite an ask in terms of a drug. However, there is a class of drugs that have been used more so, if I'm sticking more to the peripheral nervous system, called complement inhibitors. And there are trials underway in a condition called CIDP, chronic inflammatory demyelinating polyneuropathy. Complement is part of the immune system as well, and it has a role in many things, including a lot of autoimmune conditions. And so it's true to say that patients with CIDP are undergoing trials with complement inhibitors, and I think that could have applicability in the MAG setting, but it's really difficult to get companies to go into this particular area. But hopefully, through the CIDP trials, we might be able to try and persuade the same companies to perhaps consider doing similar studies in the MAG setting.
Over here.
Oh, there. Okay. Yep.
Is a MAG antibody IgM test of, say, 60 or 70,000 indicative of peripheral neuropathy, and are BTK inhibitors useful in treating that?
So I think the first thing is there clinically a peripheral neuropathy? That's number one. So does the individual actually have symptoms of a neuropathy, and is it confirmed on testing? The next thing is the level of the MAG you mentioned, 60 or 70,000, is strong. It's a strongly positive titer of the antibody. But there still needs to be an association that, as far as we can tell, connects the two, the nerve symptoms or damage and the MAG. So that is something that one would have to do on an individual basis, assessing the patient and then deciding whether they need treatment. And the third question, I think, was about BTKIs. They could well have a role. I think there are studies underway. At the end of the day, we want to try and suppress the system that's producing the MAG antibodies. So whichever way that one can do that, which is to treat the underlying cells, is the way forward. And BTKIs are one of those tools in the box. Any others, or shall we move? We can move to the next case otherwise. Okay, so case number 2 is a guy called Ben, 60-year-old man whose symptoms began 3 years before we saw him. He began to feel unbalanced on his bike, and then he felt unbalanced when walking. He developed numbness in his feet 2 years prior to seeing us, reduced sensation in the hands, reduced grip, poor writing, and he was worse mobilizing in the dark. So, for example, if he had to go up to the toilet in the night, he really struggled. He was having also to sit down to wash his hair because he couldn't stand up without wobbling if he closed his eyes, and he was using the handrail to pull himself up the stairs. So from that history alone, we can glean quite a lot of information. He's got problems with balance. Now that could be from the back of the brain, the cerebellum. It could be from the joint position sense problems. It could be due to foot drop, because your ankles act as a lever to keep you straight. You also know that he's got sensory symptoms, but he's also got weakness. So his hand grip is worse, and he's having to pull himself up the stairs. So that tells us he's probably getting weak in his legs as well. So it sounds like motor and sensory from the history alone. On examination, he had a very cautious gait. In other words, he was walking very, very carefully, and it was high stepping because he had to lift his feet in order to, he had foot drop, so he had to step very high so his foot would get off the ground. He was unable to stand on his tiptoes, which is a really useful test in the clinic, actually, because if you stand on your tiptoes, you're lifting your weight. And if you stand on your heels, that's another good, quick measure of power. He had weak hand muscles on testing. There were no reflexes present. And he also had reduced vibration, joint position sense, and pinprick. So sensory disturbance variably to the hips or the ankles and to the mid-calf. So these kind of sensations are testing slightly different pathways, but basically he's got sensory problems as well as motor. So he had nerve conduction tests, and this showed that there was conduction slowing and axonal loss. So in other words, the evidence from the electrical study showed that the electricity was going much more slowly through his axons, his wires. And it was rather patchy. There were other features on the nerve conduction that were informative, and he was deteriorating very quickly between 23 and 25. His blood showed an IgM paraprotein of 7 grams per liter, and based on his examination, we went on to image his brain and his spine, primarily looking to see the lower back, if there were any issues there. And indeed, he had thickening and enhancement with the contrast. In other words, the cauda equina, which are the nerve roots, they brightened up with contrast. And that's not normal. It shouldn't happen. It suggests something is going on there. So the cauda equina is so called because it looks like the tail of a horse. That's sort of equine is horse, cauda is the tail. And as the nerves come out from the bottom of the spinal cord, they spread out in this way, and they supply structures sort of south of that area. And you can see here, I mean, it's obviously quite a technical picture, but when we looked at the section through that area, we could see that the cauda equina nerve roots were thickened, and there was enhancement of those roots as well. So we figured there was something going on in the nerve roots. Now, the nerve roots are actually outside the spinal cord. They're not part of the central nervous system, but they are obviously very closely associated with that. And this was concerning enough for us to go ahead and do a lumbar puncture. we found in his spinal fluid he had high protein, he had white cells in his CSF, which one should never have. He also had, when we looked into that in more detail, these white cells were B cells, and they had the sort of signature of lymphoplasmacytic cells. And in the context of having an IgM in his blood, this kind of fit very much with what we were suspecting. And furthermore, we did some genetic studies, and we found these cells to be clonal and consistent with basically lymphoma in the central nervous system. So his bone marrow was done and showed mid-88 mutated lymphoplasmacytic lymphoma, about 20% infiltration. So he basically has Bing-Neill syndrome. So the conclusions of our clinic were that he obviously had a neuropathy. It was related to the WM through the fact that the WM cells had migrated into the spinal area and were infiltrating his nerve roots and floating around this spinal fluid. He had a pattern which was progressive. It was affecting strength and sensation. It was a bit patchy when we examined him, but there were multiple nerves affected. And so the treatment, we then had to think about which treatment to give. And Steve Ansell talked about the blood-brain barrier, which is a physiological barrier that is designed to keep toxins out of the central nervous system. So we're very lucky to have it. But if you need to treat disease in the central nervous system, you need something that will cross that barrier. And the other thing, of course, we did was to attend to some of his disability issues to try and help him pending the treatment. So various medicines do cross the blood-brain barrier. And when we are considering what to use, we decide on, is it just disease in the central nervous system that needs treatment, or is it the bone marrow, or is it both? We also take account of the fitness and age of the patient. But it's important to bear in mind that if fitness is impaired because of the Bing-Neill syndrome, the only way to get that patient fitter is to treat the Bing-Neill syndrome. So that has to be separated from other kinds of fitness problems like medical incapacity due to heart disease or something of that sort. So yeah, Bing-Neill is a rare manifestation of WM. I suspect it's not as rare as people think, but we don't look for it necessarily unless you're thinking about it in seeing patients. And the clinical symptoms are very diverse. So it can present as problems with cognition or thinking, poor memory. It can present with specific neurological deficits, like we have 12 cranial nerves which supply our head and neck. So some people can develop problems with their eyes, double vision, drooping of the face, problems with using the tongue, etc. So those are the cranial nerve problems. Sometimes you can get lumpy disease in the brain, although that's less common. You can get cells depositing all around the the covering of the brain, called the meninges. And because it's a slow process, quite often there's a delay between the initial symptoms and the actual diagnosis. Someone has to decide to interrogate the central nervous system with an MRI or lumbar puncture. And it's also important to rule out aggressive lymphoma in the central nervous system because Bing-Neill is not an aggressive disease. So not everyone needs treatment for Bing-Neill syndrome, to be honest. We have occasionally found patients by chance because they had a symptom which then settled, and we've observed them. But if they are symptomatic, then you can use chemotherapy and rituximab combinations. Certain chemotherapies need to be given at very high doses in order to penetrate the blood-brain barrier. I would say many doctors think that is a very aggressive way to treat Bing-Neill syndrome. In our practice, we have seen people with very heavy burden of disease in the central nervous system. Someone asked earlier about the spinal cord. We've seen someone with awful infiltration of the spinal cord, which was really affecting him from here down. and also heavy involvement in the brain, and he was a young patient. So in his case, we used high-dose chemotherapy to debulk him. But BTK inhibitors are very effective too, but they are a bit more gradual in the way they work. And quite honestly, in my experience of quite a few scores of patients, sometimes BTK inhibitors work, but sometimes they don't. And sometimes chemo works and sometimes it doesn't. So there's really no way of telling exactly who's going to respond to what. Supportive treatments I keep emphasizing because they're often forgotten, and they can really help a lot in terms of functionality. Mobility aids, adjusting cutlery and other things, environmental modifications to help, and appropriate footwear. If you have sensory disturbance, numbness in your feet, look at them regularly so that you don't miss damage. You may have hurt your foot and then it may become ulcerated or something like that. That's very important as well. In my experience, Bing-Neal syndrome responds very well to treatment in general. We have many patients who have done really well and remain in remission. Some have needed further treatment for relapse, so we obviously have to keep monitoring them. The way we monitor varies. We don't necessarily repeat lumbar punctures on a regular basis or imaging. It depends. In the early phase of following treatment, we will, but once we get a feel for the stability, especially if someone's on a BTK inhibitor, we go mainly by clinical assessment. And if they're well, we simply go by the history, we see them in clinic, we carry on their treatment. If there's a blip, then we will consider re-imaging and doing another lumbar puncture. It can take quite a long time for disease to respond to treatment in Bing-Neal syndrome. But I have seen, for example, a gentleman who was diagnosed with dementia and he had moved into a nursing home. He was made it with he had a diagnosis of Bing-Neal in the end, and over 6 months he got better and better, and then he went actually back to his own home and is fully independent. So it can take time, but it can work, the treatments. So any questions about Bing-Neal syndrome? I think Steve answered some already this morning. Okay, we'll move on. So the third and final case is a 57-year-old woman with a 3-year history of pins and needles in the fingers and a crawling sensation in her feet and legs, which gradually progressed to more like a stabbing, sort of jabbing sensation. Her balance deteriorated, she became more unsteady, and she eventually needed a 4-wheel frame. She developed urinary incontinence. She was quite lightheaded when she stood up, and she had been losing weight and had reduced appetite, and also had dryness of the eyes, which is actually quite common. Many people have dry eyes, so don't think that is a sign of something terrible. In her case, the examination showed that when a light was shone on her eyes, her pupillary reflex wasn't very good. She had foot drop on both sides. She had weakness in her hands and legs, reduced vibration, reduced joint position sense, and reduced pinprick. Now, the relevance of the pupillary reflex is that this is one of the parts of the nervous system that comes under the autonomic system. So that was something that was picked up by my neurology colleague as being relevant in the context of her history as well. She had nerve conduction tests which showed a length-dependent sensory motor axonal neuropathy, and she also had evidence of carpal tunnel syndrome on both sides. Now, the carpal tunnel is a sort of narrow channel in your wrist through which your median nerve goes, and it's a bony like canal, and it's covered by a ligament, quite separately from WM, people can get carpal tunnel syndrome due to arthritis, etc. And sometimes you get a carpal tunnel release, and then the symptoms that you're getting, usually these fingers and possibly weakness, that settles. So she had in both sides, which again was a bit of an alarm bell for us. On the right, you can see this is a blood pressure monitoring system. It was a little bit erratic, and she had a very steep fall in her blood pressure when she stood up. So she had what's known as orthostatic hypotension. Furthermore, that when she didn't have an appropriate response to her heart rate. So normally if your blood pressure drops, your heart pumps quicker to compensate, and that wasn't happening. So we went on to do further tests. She had an IgM lambda paraprotein of 10 grams per liter, and her bone marrow showed infiltration by LPL. Now, because of the clinical features, we were suspecting this thing called amyloidosis, which is this misfolded protein that is a bit like scrambled egg at the bottom of a pan, which deposits in many tissues. It can deposit in the liver, the kidneys, the bone marrow, the nervous system, and it can affect the autonomic nervous system. That's often one of the big features, and that can affect the way the gut works, and many other functions. So her test was indeed positive for amyloid. There's a special stain called Congo Red, which is not an automatically done stain. You have to ask for it if you suspect amyloid. And if you put it under a light, it comes up with this apple green. So she had confirmed amyloid deposits. And she was also found on what's called a SAP scan to have amyloid in her spleen as well. So, but she didn't have any, to my knowledge, she didn't have any cardiac amyloid or renal, which is a plus. So she did indeed have a neuropathy. That was our conclusion. It was and is related to her Waldenström, and it fits with AL amyloidosis. And the relevance of the carpal tunnel is that amyloid is known to deposit in the carpal tunnel. And sometimes diagnosis of amyloid is made by carpal tunnel release and examination of the tissue under the microscope. Other things that can happen is you can get an enlarged tongue with grooves. That's another feature. And you can also get bruising and bleeding because the amyloid protein can bind certain clotting factors. So what do we do about amyloid? Do we treat it any differently? The answer is yes. It's one of the less common reasons to give treatment more aggressively and a bit more quickly compared to most people with WM. Now, because the protein is produced by plasma cells in the bone marrow primarily, I mean, that's their job, as opposed to the B cells, we in our center are quite keen on Velcade-based therapy. So we often use daratumumab, Velcade, and dexamethasone. Daratumumab is like rituximab against plasma cells. So we use this combination to try and deplete the plasma cells so that the amyloid deposition, the amyloid protein isn't produced as quickly. We know that Velcade works in WM from previous trials. An alternative is bendamustine and rituximab, which can also work to contain this pretty well and induce a deep remission, or the other forms of our chemotherapy. And for those who are young enough, fit enough, we tend to do an autologous stem cell transplant to consolidate the response and hold on to it. Trials have shown, not very big ones, but neither ibrutinib or zanubrutinib are especially effective in amyloid, so that is definitely not something we aim for to begin with. Sometimes we have gone on to use that if other therapies are not effective enough, but it's not the choice, it's not the first choice in the setting of amyloid. There are some trials that disrupt protein deposits that are underway, and bispecific antibodies that Steve talked about earlier there are trials which include amyloid in the IgM setting, which are being used as well, as are degraders, BTK degraders. So apart from supportive care for amyloid and pain management, you also need to treat any heart failure or fluid overload, etc. You need to get other specialists involved. You can you treat the underlying disease, as I mentioned. You can consider carpal tunnel decompression, treatment of pain. It's often a very painful neuropathy. If there are bowel issues, you can use appropriate medication to either speed the bowels up or slow them down, whichever is the problem. There are medications to raise blood pressure if it keeps falling. And again, there are adaptations for walking, etc. If effective therapy is started in amyloidosis, it can work, but it takes months, and the rate of improvement depends on the degree to which organs have been affected. So it just does take a very, very long time. One has to just keep on at it, measure the light chains, make sure that you're on the right track, and if you're not, change the treatment. But it's something that can respond. And so everyone would approach this with great importance and speed to try and get the right response and quickly. I think preferably one should consult with an amyloidosis center because they have other ways of measuring organ problems, which can then be monitored going forward. So in summary, I've presented 3 cases, one of anti-MAG, one Bing-Neal, one AL amyloidosis. I've hopefully illustrated the things that can go along with in terms of investigation, supportive measures, treatment approaches. Our center has coined the term neurohematology. We have a clinic in which we work together. I think that's a really good model. I think the IWMF is hoping to put together a list of neurologists with a special interest in peripheral nerves so that you can find out who they are and where they are. And I think the same in Europe, that the attempt is being made there. The important thing is to find out exactly what is causing the neuropathy, not jump the gun, and make a specific treatment plan for individual patients. These are the key things. I think it's in your handouts, the things you should mention when seeing your doctor. When do the symptoms start? Have they come on gradually or quickly? How are you affected? Pain, balance, strength, tremor. Is it symmetrical or asymmetrical? Does anything make it worse? Could you have, if you have back pain, mention that. Because low back pain and sort of arthritis is common and it can cause what sounds like a neuropathy, and how are the symptoms impacting on your function. So be prepared with these things when you see your doctor because it helps them to think it through. And get active within your limits, seek help from therapists. Physiotherapy is not always easy to come by, speaking for the NHS, but having a neurophysiotherapist give you advice on how to get better is very, very helpful and important. And that's the end of my talk. Thank you very much. There's a question there.
Hi. I don't have any of the symptoms that the Bing-Neal sufferers have in this room, but I have a curious phenomenon where I'm scratching only the right side of my stomach, and it's not always itchy, but it is sometimes. Is that some kind of precursor, or is that something completely different?
Is there a rash?
No.
No. I don't think it's necessarily a precursor in the absence of anything else.
Okay, thank you.
Yes, I have neuropathy, and mine is not related to WM. They've done 2 different tests. So my question really is, if you have peripheral neuropathy, what's the difference, and what's the difference in treatment?
Do you know what it is related to? Has that been attributed in some way?
They have no idea where it came from, and I've had it for, I don't know, more than 20 years. And it doesn't seem to get any worse, and I have some of the symptoms that you're describing in your presentation, but I've been to several neurologists, and they say, well, We don't know how it started, where it came from, or any of that, but still, my question gets back, if it's neuropathy, what's the real difference? Why should there be a difference? If you have peripheral neuropathy, should it not affect the same nerves?
Not necessarily at all, actually. I think there are probably thousands of causes of neuropathy. Some of them are genetic. And the reason we know that is because there's been a sort of whole genome project going on in many countries, actually. But in the UK, there was something called the 100,000 Genomes Project, where people's genomes were examined. And as time has gone on, a number of unexplained neuropathies have been put down to a genetic cause, which is often something that happens later in life and is very, very slow and doesn't lead to anything. And the pathology varies, so it depends what gene is affected. It's usually a gene to do with nerve function. So in our practice, we have come across patients who don't fit the pattern, and they have what was formerly called idiopathic neuropathy, which means no one knows the cause. They've excluded every other cause. But sometimes genetic tests come up positive. Now, that doesn't mean one can do something about it, but it's sometimes helpful to know if there's a cause, and therefore what you might expect going forward. Sounds to me that something that's very slow and gradual and more quite stable could be down to that. And overall, I imagine the prognosis is not bad at all.
Time for one more? One more?
We have one more question, is that okay?
Any more questions?
We have one more here. We had one more right here.
Are there any more questions?
Yeah, we have one more right here.
Oh, go ahead.
I saw you highlighted a Velcade-based treatment. I thought that Velcade often caused neuropathy, and I was surprised to see that there. Could you elucidate on that a little more?
That's a very good spot, actually. In the setting of something like amyloid, where we need to treat vigorously and rapidly, our experience has shown that reducing the damage, inducing cells, is likely to improve the neuropathy quicker than the Velcade causes a side effect of neuropathy. So we have used it in many cases, and it's proven effective. And actually, Velcade has a very bad reputation, perhaps a worse reputation than it deserves, because in the early days it was given intravenously. But for the last, I don't know how many years, it's been given subcutaneously, and the risk of neuropathy has been reduced. It's not zero, but it's been reduced.
One last question.
Just listening to the presentation and the points that are there, it would seem like A1 would be a viable tool. Is it being used much? AIs, I guess I need to say.
Say again?
The AI, is it being used as a tool by putting in all the points that you have, the symptoms?
AI? Oh, right, okay.
I'm sorry, I said.
No, that's fine. I think like other people have said in previous answers to that question, the answer is I think people are doing that more and more, but not, I wouldn't say in a very controlled or set out way. I think that is to come. So I agree that using AI, if you feed in symptoms, it can probably give you the kind of risk, the likelihood of a diagnosis, but it still needs actual eye to make sense of it, I think, in the end.